Shao Liang Chen, Mike Gibson here, talking to you about the DK Crush 8 trial comparing Ivus to PCI and complex bifurcation lesions. Shao Liang, talk to us about what you found.
Okay, thank you very much, Dr. Gibson. So, actually, both ACC and ESC guidelines have recommended intravascular image-guided PCI for SCS, particularly for complex lesion, to be 1A, including a coronary bifurcation lesion. So far, there was only one randomized study comparing OCT-guided and angiography-guided uh, bifurcation PCI. Even the primary endpoint was significant, but none of the individual component of the primary endpoint was different. Probably it's mainly because of most of the lesion, including that trial, are simple lesion, uh, as a side branch lesion length less than 8 millimeter. So last year we performed our IPD analysis from our full DKQH trial. So the final result confirmed the consistent effect of DK-Quarch, particularly for complex bifurcation lesion. But from the previous trial, Ivus guidance was only used in less than 50%. And from our DK-Quarch definition 2 trial, so the 1-year TF rate still high up to 6% in DK group. So the remaining question is whether if Ivus guidance may further reduce clinical events in DK culture for complex bifurcation lesion. This is our aims. So the key inclusion criteria are complex bifurcation lesion, as well as the main vessel QFR minimal zero point 0.8. Patient with STEMI younger than 24 hours will be excluded from the trial. So the primary endpoint was a 1-year target vessel failure, including cardiac death, target vessel myocardial infarction, or clinically driven TVR. So finally, we assumed the 1-year TVF rate will be 11% in the angiography guided group and 4.5 in the IVUS group. So
Mhm.
finally, 558 patients were included into this trial and randomized to IVUS guided and angiography guided two groups. So we performed ITT analysis. Also, we performed post-hoc landmark, fine-grained competing risk model, as well as the per protocol analysis. Because DCAT quality consists of several steps, so we recommend IVUS assessment at each step of DCAT quality technique as a figure shows. So baseline characteristics are comparable between two groups. So almost the 45% of lesion localized at distal left main. A decay quality technique was used in greater than 96% of patients. After first rewire, because the proximal rewire is a key step of decay quality technique. So after the first rewire, I was assessment reduced to only 82.7%. And during the IVUS assessment, there are several findings, particularly immediately after the first rewiring. So the distal wiring in 41% of the patient, and after balloon crush, incomplete crush seen in 78 patients. I think these are very important. So by 1 year follow-up, the TVF rate was 6.1% in the IVUS guided group compared to 14.1% in the angiography guided group. When per-procedure myocardial infarction excluded from the TVF, so the difference was sustained, uh, mainly driven by a high rate of tidal vessel myocardial infarction and clinical-driven TVR. And according to pre-specified optimal was guided PCI, so the benefit of DK quash was only achieved if the optimal PCI, according to Ivus definition, was achieved. Otherwise, there was no any difference between suboptimal PCI and angiography guided PCI. So there is no subgroup analysis and no interaction. So finally, in conclusion, in the present randomized trial, I was guided PCI, guided GK quality lead to lower 1-year rate of target vessel failure compared to angiography. This benefit was achieved largely through achievement of Ivus-defined optimization targets rather than Ivus use alone. Thank you.
Well, thank you, Shao Liang. Congratulations. Very clear results. And again, the audience can see the results, as you just saw, published simultaneously in JACC. Thanks for sharing with us today.